Good afternoon, everybody. When this topic was given, I thought it was purely clinical, and there was a lot of overlap since morning session on the endpoint selection. So I thought I will just give you a brief idea of what is the basis of selecting the efficacy and toxicity endpoints, and what are the statistical considerations which are required, and a bit of literature search which gave me endpoints used in the literature, and finally end up with a different approach called the risk-benefit analysis. As I said, the endpoints being selected for any trial actually depends on the study setting and the objective. For example, in metronomic studies, they can be categorized based on the setting as neoadjuvant, where the objective is to reduce the tumor size and increase life. Perioperative setting, where we look at the increase in life and decrease in metastatic disease. The adjuvant setting, where we look at the increase in life, and in a palliative setting, where we look at decrease in symptoms and increase in quality of life. I will just show you a couple of slides on neoadjuvant and adjuvant setting, where the endpoints are looked in different way. So this is from the literature, where the metronomic chemotherapy in the neoadjuvant setting has been reported. There are three studies, if you see in this. Most of them are phase 2 here, and they are from breast cancers, and the outcome which was considered was the pathological, the PCR and ORR, that is objective response rate, and the breast conservation rate. Okay, and trials looking at the metronomic chemotherapy in the neoadjuvant setting had looked at various endpoints, and this table shows how they have been looked at different cancers. And in most of these cancers, the overall survival or the PCR was the endpoint, and the toxicities reported were like neutropenia, leukopenia, etc., and which can be seen from this table clearly. Now, when I did a literature search, I found a systematic review which was giving a comprehensive idea of all the endpoints which is being covered using low-dose metronomic chemotherapy. The review was actually done on some 400 and odd abstracts were searched, and they have found 80 published studies on low-dose metronomic regimens. The reviews pointed out that most often the drugs which were used in this setting were cyclophosphamide, followed by capecitabine and etoposide, etc. And coming to the design and the sample size, most of these studies were in phase 2 setting, where 60 out of 80 published literature were on phase 2 design, and they were predominantly a single arm, and multi-arm trials were very few, that is 16, and out of which the randomized trials were only 7. There were no definitive, the study was published in 2013, and there were no definitive phase 3 trial results at that point of time. If you look at the sample size, most of them were around 40. And the different sites which were considered are given at the bottom of the table. Now, commonly used primary endpoints are mostly response rate, which is complete response plus partial response. This was reported in 19 studies, and followed by progression-free survival and safety endpoints. And the criteria for assessing the response was mostly by RECIST. 47 studies have used RECIST criteria, followed by the WHO and the other criteria. Now, looking at the primary endpoints, that is the response rate and the progression-free survival, the mean response rate was around 26%, with a confidence interval ranging between 21 to 31%, and the median PFS was around 4.6 months, with a interquartile range of 3 to 7 months, and the mean DCR was 56.3, interval between 51 to 61.6. Now, coming to the toxicity which has been looked at in all these reports, the major toxicity reported are neutropenia, lymphopenia, and leukopenia, and followed by other toxicities like non-hematological toxicities. Now, Apart from this efficacy and safety endpoints, a major concern is on the quality of life, and I just did a small search wherein I found 3 studies, the recent ones, which is looking at primary endpoint as a quality of life. The first one is the study on head and neck by Dr. Vanitha Narona et al. TMH, where they looked at the metronomic and celecoxib versus cisplatin chemotherapy on 87 patients, where the primary endpoint was quality of life. They found a significant improvement in pain, only QLQ-C30 score, from baseline to 3 weeks and 6 weeks also. This was a recent article published in Support Cancer Care. And there's another study in breast cancer where the primary endpoint was quality of life, and they have compared these regimens, and then they actually find a high proportion of patients showed a significant improvement or no changes. This was also published recently, and these are the few studies where the quality of life is looked at along with other endpoints or as a primary endpoint. Now, coming to the statistical consideration, we had a good session in the morning by Dr. Gupta, where he has covered different designs 2 and 3. But the question which often arises in our mind is, how does the results of phase 2 trial warrant a phase 3 trial? So from statistics point of view, what are the things we should keep in mind when we answer this question? One is, we can look at because most of these studies are phase 2 and we are trying to evaluate different regimens, we can have an interim analysis plan with proper stopping rules. There are few designs like Simon 2-stage design, and this another design which is coming recently is the integrated phase 2 or 3 design. We have done this integrated phase 2 design, 2-3 integrated design for a recent study which Dr. Kumar had presented in the morning. It's a randomized clinical trial evaluating the efficacy and safety of the addition of oral metronomic chemotherapy after completing of standard chemoradiation versus observation in carcinoma esophagus and gastroesophageal junction. So what was the input data in that? They have assumed a median overall survival in the control group of 16 months. The progression-free survival was 6 months, and the accrual rate of 7 per month, with a power of end of the OS study which is around 80%. And with all this input data, what was observed was, if you're planning to do a single overall study, what is the scenario? If you do an independent phase 2 study with progression, what could be the events and the numbers required? And if you see a single futility study based on the OS, you would require around 394 patients, whereas if you do an integrated, you require slightly more, 400 and odd patients. But if you see the duration is, you're saving a lot of time by doing this integrated phase 2 study. So the saving which you make from this integrated design is around 2 years, and we also have a kind of 25% reduction in the sample size by planning this integrated design. Now, someone in the morning in the audience asked about the analysis of, weighing the risk and benefits. We have been seeing in the reports where the efficacy and the toxicity endpoints are being reported in isolation, and it becomes very difficult when we compare different regimens and to choose the best one. So the risk-benefit analysis is one which will help us actually to weigh the pros and cons of each intervention by looking at both risk and the benefits. The conventional analysis looks only at safety and efficacy, whereas this takes into account both, and it helps us to kind of choose the regimens. Risks are nothing but any detrimental effects that can be attributed to the product or that are otherwise of concern for the undesirable effect on patient's health status, such as cardiac toxicity or neutropenia and rash. Benefits could be anything like a clinical response, progression-free survival, patient-reported outcomes, and overall survival of the target population associated with the drug. Now, there are different methods of doing a risk and benefit analysis. I'll just mention 3 and detail about one method. The first one is called the Q-twist, that is quality adjusted time without symptoms and toxicity. And the second method is the BLRA, which is benefit less risk analysis. And the last one, which we often use, is a number needed to treat and number needed to harm. If you look at the Q-twist, the steps are like you define the quality of life oriented endpoints, partition the overall survival time, and you compare the treatment groups with respect to the quality adjusted survival. A quality adjusted survival model is constructed using utility coefficients for the time period with toxic effects and also to reflect the states of health by giving a weightage of 0 and 1. Then we calculate the twist, we assign a weightage of 1, and then for death we assign a weightage of 0, and this formula is used to calculate the Q twist. If you see this analysis being reported in the literature where they are comparing the adjuvant radiotherapy and chemotherapy for resectable rectal cancer, the first figure actually, as Q twist analysis said, that you're going to partition the survival analysis into 3 parts. One is for the relapse, and one area which tells you about the time without symptoms and toxicity, and the last one is the toxicity, time spent in toxicity. Sorry. So the first one, figure A, it gives the Q twist analysis for the adjuvant chemotherapy and radiotherapy, and the figure B is for adjuvant radiotherapy alone. If you see this figure, the overall survival, the follow-up time is still 5 years, and the first figure, that is A, if you see that where the combination therapy has been considered, there is a longer time spent on toxicity and the relapse period is also less, but the quality time without symptoms and toxicity is more as compared to the adjuvant radiation therapy alone. So this type of analysis helps us to compare 2 regimens and see which one is better, because it considers both the time spent due to toxicity, what is the time lost, and due to relapse. Now this study has seen this, they've divided the components of Q twist. One is the toxicity time, the twist, and the relapse. If you see the Q twist, the radiotherapy and chemotherapy is showing 43.9 months, and the radiotherapy alone group is showing 38 months. So there is a absolute difference of 5.9 months in the radiotherapy and chemotherapy arm, although the toxicity time was longer in that arm and also the relapse was lesser. So this analysis helps us to kind of look both into consideration and compare the 2 treatment regimens. Thank you.